the bereavement office will call you to come and see how you're doing, make sure you're emotionally okay. But yeah, that's what usually happens after a mortality. So a typical day in the A&E is very fast. It moves with the speed of light. It's so bad that they have to remind us to take our breaks because you can get so caught up that you don't even remember to have your breaks. That's how it is. So it is a very, sorry, it's a very, very demanding department and of resilience and teamwork. What are some of the common challenges we face working in the A&E? So this is regardless of your role in the A&E. You have a high volume of patients. You can have on average 100, 120 patients in the A&E at every given point in time. And then you have almost 50, 60 patients that are waiting to be seen at every given point in time. You would have heard that in the UK, people used to wait in the A&E for 8, 10 hours just to see a doctor. All right. That's because we have high volume of patients coming in and not just the waiting room from the ambulance, people that are rushed in, emergencies and stuff. So high volume of patients. You need to be on your toes with making decisions. So you need to make decisions really quickly. Every consultant has 10, 15 minutes of seeing the patient. You should have a plan. You should be ready to go. And so that trickles down into being a fast-paced environment. You have to move really quickly. Time. Another thing is that you have really unsociable hours. So shifts are not your normal 9 to 5. Like today, I worked a 10 a.m. to 7 p.m. shift. So you have other patterns like 2 p.m. to 10:30, 3 till midnight, really weird unsociable hours. So it's not like you can plan with it. Your hours keep changing every week, ever so often. It's also a very high stress environment. So you are under a lot of pressure, under a lot of stress. People's lives are literally in your hand. They are not just coming waiting for you. There are people that are actually in critical condition that need, treatment and management, spot on. So it's a lot of stress. And then there's the non-continuity of care. So if you are someone that wants to up, of course, take the patient's name or hospital number or something, keep a record, and then follow the patient. But it's not really there. Unlike something like internal medicine where the patient is on the ward and you are going back ever so often to check and okay. And the last challenge is mortality. So you deal with a lot of deaths. Not as much, it's not a lot, yeah, but ever so often you get the few patients that come in either already dead or they die in the A&E. So you should be prepared for that as well. So most of the time they give you, grieving counseling. You have the bereavement office will call you to come and see how you're doing, make sure you're emotionally okay. But yeah, that's what usually happens after a mortality. After talking about all the terrible things about A&E, let's have a quick chat about some of the pros. Now, I really sat down to think about this one because it felt like I was trying to convince myself as well. But one of the things I love about working single day is different. Like today, the first patient I saw had suspected to have glandular fever. That would have, possibly led to some, cardiac symptoms as well, which was really interesting. I've never really seen any case like that before. Bow syndrome. Yeah, I've only seen two. This is the second one. And it was really interesting to see. So no 2 days would be the same. Yeah. Every single day you are seeing different cases, different types of patients. Of course, there are the usual days where you are seeing only patients with chest pain, or headache, but it's always versatile. Even those chest pains, they will not come with the same presentation. It's not the same thing. Okay, so it's a very interesting place to work. Another advantage is that it improves your clinical knowledge and skill. So there are a lot of things that I've had to do now in the A&E that as I feel has improved my skills. It's just a given. You are seeing different things. You have to have, a basic knowledge about how to identify the critical conditions, the emergency conditions, and it's something that helps you in the long run, especially when you're preparing for exams and things like that. You are seeing the patient getting better in real time. So most of the time they come in really bad shape, and then you get to see them, stabilize them, and then send them off on their way. Something like anaphylaxis is one I really love seeing, because you literally see the patient recover in real time, and you're like, woof, we are magicians. All right, it's very satisfying to see the patient actually improve in real time. Now, this last one, yeah, if there's any reason why I'm going to consider doing A&E in this life, is this one. There's no word round. You're not going to stand for hours and be taking notes where one consultant is dictating for you. Nothing like that. It's so nice. I love it. So we don't do word rounds in A&E. We do board rounds where we look at the board and be like, okay, what's going on in the department? Really fast, really quickly. Tell us what's going on. Do you have a plan? And we move on. Very quick, very easy. And then the turnout of patients is very fast. So there's really no point doing a ward round. Okay. And typically A&E is not even supposed to be a ward. So there's no ward round. All right. So if you are someone that gets really tensed about ward rounds, A&E is really love in, working in A&E. I hope I'm following so far. I hope I haven't lost anybody. I'm just trying to run through it in the chat. Um, I'll get to it soon. All right. So if you're considering doing specialty training in emergency department, these are some of the pathways to follow. Now, the first one is usually the most common one, and I think is one that if you've just you've done your house job, you've done, NYSC or 1 year of practice, you can consider the first one, which is the ACCS emergency medicine, the acute care common stem emergency medicine. So I think ITU, anesthesia and acute medicine also go through ACCS, but emergency medicine, this is like the only way to get in from ST1. Okay, so you do have to go through ACCS-EM if you are just starting. So you need to write the MSRA. Now, MSRA, now you have to have a really, really high score for you to be able to even pass to the interview stage. Now, in those days, there's the caveat of if you score a really high, if you score really high in the MSRA, you can skip the interview and then go straight to your job offers. But now, I think this year, they changed it. So even though if you score 600, you will still have to do an interview, because MSRA now makes only 40% of your general score. So if you pass the MSRA, you meet the score that you can use to get to the interview stage. You get to the interview stage. The interview now consists of 2 stations, I think. So one is a clinical station. The other one is just you talking with the panel. And then after that, they'll give you a score, which is about 60% of your mark. I've heard that they do look at your portfolio as well, but it's not always the case, especially for IMGs, because they know we don't have portfolios. But yeah, they also, a good portfolio helps, so they say, but it's not always relevant, especially if you are going through, ACCS-EM. So you should be good. So if you do pass those stages, then you're good to go. You start your specialty training from ST1. Now, this is a run-through program. So it means if you get in ST1, you don't have to worry yourself for the next 6-7 years. So I think, EM training is 7 years in total. You get I think they give you a sponsorship for 5 years. So if you've not gotten your ILR by then, which you are supposed to after 5 years, they can then extend it for the rest of your training. But from the jump, once you get in, that's 5 years, because it is a run-through program, meaning you don't have to break it in between and then write another exam to go into higher specialty. No, you go straight from ST1, ST2, ST3, ST4, ST5, ST6, ST7, and you become a consultant, which is really beautiful. I find it that it's one of the more straightforward specialties. Okay. The second one is for anyone that has been in the UK for a while. So someone like myself, I can consider going through the DREAM pathway. So you need at least 2 years of emergency medicine experience, and you need to have written your MRChem exam. So the MRChem is like their specialty exam. So while you're even doing ACCS EM, you do need to take the MRChem exams. I think step 1, step 2, not really step, the primary, S-bar, and another one, OSCE, I think. And then you also need the FRChem. It's a lot of exams, okay? But for the dream pathway, you just need to pass the MRChem exam. Some people say you do have to pass the 3 for you to be able to get in, but I've seen someone that did only the first one and the second one. I was able to, get his foot through the door. So for this one, you start at ST3, if I'm correct. I think ST2, but you only do 6 years. So instead of doing the whole, no, you only do 5 years. So instead of doing the whole 7 years, you do 5 years because you would have already gotten 2 years of emergency medicine experience. So if you've worked in acute medicine, if you've worked in emergency medicine, if you worked in ITU, you can go through this dream pathway. So it's also another consideration for people that have been in the UK trying the MSRA is not working, then you can go through the dream pathway. I know a couple of people I work with at the moment that are trying to go through this. Already started training in the abroad, so in your home country, wherever you are. If you've already started, maybe you're already a senior registrar or even already a consultant or something, and you are coming to the UK, consider the CSER pathway. All right. I don't really know a lot about this pathway because it's one I have not really looked into myself. But if you do fit into this category, please do some research because here is really plausible, but you do need to write all your exams and all that drama as well. Okay. But yeah, so these are the main pathways into specialty training. Now, it's all nice and good, but there are a lot of challenges when it comes to working in the NHS in the UK as an IMG, and then especially somewhere as high pressure as the A&E. So now some of the things I found challenging was, one, the cultural differences. It's definitely different from what you are used to back home. So it's kind of challenging to get integrated into working in the NHS. So someone like me, I had stopped working for a year before I started working in the NHS, and it felt like I didn't know what I was doing. And then just coming back and coming into a new system, it was a lot trying to figure out how the NHS worked. Okay, but give yourself some time. You'll be able to adapt eventually. The next thing is trying to find out, what the practices in the NHS, basically. So all their rules, all their guidelines, they were things I found really, really tedious. Like every single thing have a protocol, have a guideline, have an SOP, something you have to check before you. I'm like, this is simple chest pain. So please check the guideline, So it was really, really difficult at first. But I found out that, asking questions, knowing that, well, I don't really need to use my brain too much. I need to crack my head, just check the guideline. Was kind of like how I started looking at it. So even if I know it, check the guideline, just so you're on the safe side and you're doing what you need to do as per the trust guideline and NICE guideline, whatever guideline is there. Now, I would say stay positive. Being an IMG is a very challenging place to be, especially now in the climate in the UK at the moment. So if you know that, you want to work in the A&E or you want to do emergency medicine specialty, keep at it. It might be challenging, of course. Every single pathway is challenging, but stay positive and gather as much information as you can so that you can navigate whatever challenges that come. But try and stay positive because these challenges are semantic, right? So some of the things that can help you is that make sure that it's something you want to do. So build a foundation that you make sure that is what you want. Don't go into any specialty because someone is forcing you to do it or everybody is doing it, especially something like GP. Or if you feel like it's GP is what you want to do GP. But if it's just because, GP is just 3 years, everybody's doing GP, then that won't really push you through the whole thing. You might finish your whole GP training and still want to do something else. Okay, so why not just start with the one you want to do in the first place? Okay, try and stay committed to a specialty. So someone advised me recently after I wrote my second MSRA and told me that, focus on one specialty, choose one such that that that's what you are fighting for. Yeah, it's always good to have a backup, of course, but choose one specialty that that you want to be committed to and fight for that one. That sort of gives you some sort of direction and drive. And honestly, you feel really good if you eventually get that specialty that you have been, gone in for. Okay. Seek mentorship. It's best to have someone to show you the way. It's never easy to do it yourself. And that's why you see people in the UK, they do the whole educational supervisor, clinical supervisor, the consultants are so accessible, everybody's so accessible because they know that, at every step of the way, you do need guidance. So as IMGs, it's a different ball game for us. We have to fight and struggle on our own. Okay, which is why communities like this thriving in the NHS is very important. So seek mentors, seek, people that have been through what you are going through, people that know, how the system works, just to hold your hand and guide you through it. The last thing I would say is for continuous improvement. So always seek to continuously improve yourself. So be it taking courses, attending webinars, whatever it is, put yourself in places that would improve your chances, that would, improve your general, professional development. It's always important. They would want this is something that no matter what specialty you're doing, they would want to see. Okay. And it's also good for you as well. So you don't end up feeling stagnant. You don't end up feeling like you're not doing anything while you wait or pursue your dream specialty.